Hi, good morning all and welcome you to the Shri CPD session, Continuous Professional Development for the day. And today our topic is very convening and we'll get on to that. Uh, so this webinar link will be available from 9 a.m. to 9:50 a.m. to join and the late attendees will be entertained thereafter. Uh, not will not be entertained thereafter. And each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points. And the CPD points are strictly adhered to the NCCPD guidelines. And to improve and maintain the standards of the CPD program by the SRI, these regulations have allocated. I'd like to thank you all first for the strict adherence for the CPD regulations and for your kind compliance on this program. Today we are starting on a new journey, new topic, that is AI, artificial intelligence in health. So this is according to our Dr. Anuruddha Padiniya, who's the founder of SRI. Under his vision, we are starting the series of AI in health lecture series. So we are seeing as the SRI, the potential and the impact of the AI in the health field is now increasing rapidly, especially in the Western world. But until now, we are just far behind on this technology and also on the knowledge about AI. So as to improve the knowledge and the technology of AI in health sector in Sri Lanka, Dr. Anuruddha Padini has already begun discussions with Dr. Palitha Karunapema, who is the appointed person in the Ministry of Health regarding AI in health, and to build up a new entity in Sri Lanka to acknowledge the doctors and to bring the technology to the Sri Lanka. And as a part of that vision, today we are convening this lecture series with uh, a renowned Sri Lankan, Professor Padmini R. Ranasinghe. I give a small introduction to her as of now. She's the professor in medicine, John Hopkins School of Medicine, United States of America. And she is now the director in educational division of the John Hopkins School of Medicine. And also, she is the vice chair for the American Medical Association, the largest association for doctors in the world with more than 1 million members. So she's the vice chair now. And she's an expert panel member for the World Health Organization. And she has come to Sri Lanka for a short visit and also come to Sri with the invitation of Dr. Anuruddha Padiniya. She has been conducting lectures at the Health Tech Asia 2024 at Indonesia, and on her way back to USA, she has agreed to do this valuable lecture for us. And we are very proud to have a fellow Sri Lankan at the leading tables in the world and in the health sector. So moving on to our lecture, when you're asking questions, the question time ends at the end of the webinar. If you have a question, please type it into the your chat box. But before that, you have to change your chat setting to all panelists and attendees so your question can be answered. And if you have very specific questions about the today's lecture or any other matter, you can email us anytime at office313@gmail.com. I'm passing on to Prof. Padmini R. Ranasinghe. Madam, you're welcome.
Good morning, everyone. I'm greatly appreciate your invitation, and I'm extremely privileged and honored to be here in Sri Lanka. As you might know, some of you, I graduated from Colombo Medical School, and then I did my residency at Yale in internal medicine and preventive medicine, and now I practice at Johns Hopkins, and I'm a clinician. I'll start with my objectives. So first, as I said, I'm a clinician. So I'm going to talk about what artificial intelligence is. Essentially, it's a kind of a layman term. And second, AI applications in healthcare. And then also, there are several challenges of AI. And then some of the policy recommendations and conclusion. I want to tell you at the beginning, this is not a description of everything out there in regards to AI and health. It's a kind of a snapshot of what is out there. Disclosures, as previously mentioned, I'm a faculty at the Johns Hopkins School of Medicine. I teach patients a lot in the medicine ward and also teach medical students and residents. And at the state level, I serve as the president of the State Medical Society. It's the Maryland. And it has about over 10,000 physicians. And then also, it is a 225 years old organization. And then vice chair for Council on Science and Public Health, the American Medical Association, where our charter is to discuss what the new development in relation to science and public health, and advise AMA and guide AMA in regards to policy directions. And as I previously mentioned, this is essentially a clinician's perspective. We'll talk about a little bit like technology in healthcare. So as you all may know, like it's just in 1970, we had the first CT scan. Although we feel like CT scan have been there a very long time, but it was only until 1970 they didn't have anything like that. And in 1980, first MRI scanner was used. In 1990, we heard about that, right? When we were in medical school or getting to medical school, Human Genome Project was launched. 2000, rise in electronic health records. That started in 2000. It actually continued to grow. And late 2010, so early 2015, only that in the US, actually, the highly adoption of EHR happened. And in 2020, with the COVID and due to so many other real reasons, use of telemedicine and remote patient monitoring became widespread. And there are some other development happen at the same time, smart ambulance. So there are ambulance now out there in the world. It will say if you call 911 or 311 or whatever the emergency number is, you get into an ambulance or you are taken to an ambulance, it's connected with several devices, and you can be immediately diagnosed with VFib or some other fatal condition, and then can be taken care of by right there. And that improve your survivability and mortality improve. And then there are an emerging technology called thermal imaging cameras, can detect the breast cancer wherever you are. Sometimes you just hold into that camera and see if there are cells changing. And as I mentioned previously, telemedicine is actually taken up hugely. And during last 5 years or so, now it's actually using in every discipline and every areas in medicine to improve, one, to access, and then also, especially for vulnerable population, and improve healthcare delivery. Another concept we have, even at Hopkins, actually first described is hospital at home. People who are not that sick can be treated at home with everything that you do in the hospital setting. So they don't have to come to the emergency room. Especially it's like minor conditions like pneumonia, and you don't have like high-end technology to monitor, you can do that. And then there's another concept called telenursing, because there's a huge workforce deficit. So nurses will be sit in one room, and then you can manage certain things at a virtual level. But it's not, you cannot do everything that you do at bedside nurse, but there are certain things can be done. And when you come to AI, evolution of AI, in 1956, John McCarthy coins this term called artificial intelligence. I mean, we as doctors understand artificial intelligence is you have human intelligence, you have animal intelligence. Artificial means is the intelligence. This is made by computer. This is a capability that is similar to human capabilities or less than that, but in the computer level. And there are several levels of AI when you come to computer related. I'm going to touch upon what is augmented intelligence a little bit later. But categories of artificial intelligence for some people who may not know details of this one. But I mean, a layman term, it means like the computers which has some level of intelligence is called artificial intelligence. And machine learning. So this is like a somewhat rudimentary state of artificial intelligence where you input some data and then you give some direction and then you predict certain things. It's like a recognition of pattern. This is like one of the basic AI type. And deep learning is, on the other hand, more advanced form of machine learning where you have like a network, neural networks, it's called, and analyze various factors, including imaging. And next level is natural language processing. In addition to above, it can also interpret clinical documentation and patient interaction. It can actually capture the interaction that you have with the patient. And robotic process automation, we use heavily in patient care, not necessarily direct delivery to patient, any kind of medical care, but automating like routine tasks, repetitive tasks like scheduling appointment and managing patient data. In the advent of ChatGPT, you probably hear this all the time, large language model or LLMs. This is a powerful type of natural language processing tool, and it can actually understand and process human language. And then the basic requirement or premise is massive data set. And it can look at the data set, it can look at text and code, and it actually allowing them to grasp a complex language pattern and perform a variety of tasks that normally human can do. So it's actually, when you can, ChatGPT, it has same intelligence or maybe, I don't know, low or high, but intelligence similar to humans. And then if you look at broadly artificial intelligence, and especially when it comes to healthcare, there are three types. First one is called narrow intelligence. It is actually designed to perform specific tasks as directed by somebody outside, and it cannot think independently like humans. So you know what your directions are, you know what your database is, you know what the output is going to be. It is somewhat predictable and it's specific. But the transparency is interesting, right? And when you come to healthcare, it's very complex. We're dealing with patients' transparency. So here you don't see the transparency immediately, but you can go back and look at the code and see what the directions you have given. So it's somewhat retrievable. This is what you see now, artificial general intelligence, or AGI, and example is ChatGPT. So here, the artificial intelligence acts as similar to an human intelligence, almost like they can think, do new tasks, and come up with new knowledge. So, and here, essentially, it's a mirroring human cognitive capabilities. So this is what's going to revolutionize healthcare, and it is emerging now. And it's already been, it's out there. You can put certain symptoms and see what the diagnosis is, but we don't know what's happening behind the scene. And next step is artificial superintelligence. It's at this point, it's hypothetical, but it's going to come. It's going to surpass human intelligence. And it's actually will be used in many different disciplines, not necessarily in healthcare. But the question is, at this point, there are a lot of concern. If bad actors can use this for destroy humanity, I mean, that's a concern we have. But I mean, at this point, it's not out there, but it's going to come. So with the introduction to AI, so what is the issue? Is like, this is a new era, right? We are in the cusp of revolutionizing healthcare and every discipline because of this AI. I mean, this is not just a trend, but there's a significant shift in shaping our healthcare landscape, from patient outcome, increase efficiency, and drive innovations. Anything you name it in healthcare and other disciplines is going to change. And, as doctors, sometimes like somebody who's established, you don't like changes, right? So you like resistance to technological shift. And you like say, oh, I don't like it because this is what I have been doing something for a long time. But it become not an option anymore, because in future, healthcare is intertwined with AI and digital technologies. And if you don't learn it, kind of you lose it or you're left behind. And I know when EMR was introduced in the US, and there are physicians who didn't like the change, there was some resistance. They had to leave the profession because they said, okay, because there are, when it came in the US, there are a set of guidelines came. If you use it AI or like EMR, these are the things you have to follow. But some of the doctors didn't want to follow those recommendations. They want to do whatever they were doing before. So they had to leave the profession. But if I tell you, doctors and AI working together have a better chance of detecting breast cancer than if doctors or radiologists looking at alone. And with the fewer false alarms, because you may say, oh, you may detect another tumor, but is it really means something if it is like a benign tumor or something? But no, there's technique now, technology available. It can detect real cancer a little bit more than what doctors alone doing. And similar to that, pancreatic cancer world. It seems like there are studies done looking back on the imaging or CT scan done for patients who were diagnosed later in pancreatic cancers. AI can actually pinpoint some of the changes 3 years in advance. So if I tell you that, what you do as doctors, sometimes we are kind of educated audience, we might say, oh, maybe I'll go to AI rather than just going to a doctor. I mean, it's itself is a change in shift in like culture and how we look at healthcare. I mean, we are not there yet. Right now, it's working alongside with doctors, but the future, we don't know what's going to happen. And then, yes, technology is developing and breakthroughs are happening every day, but there's a gap in adoption and application between East and West. And the objective of this talk, I feel like it's just the beginning of a new like trajectory or new domain or what you're going to do in future. And I want to give us just a snapshot of what's happening and what the changes are happening. Want to inspire you to explore yourself. We can't cover everything what's happening right now, but it hopefully will help you to understand some so that you can explore yourself. And the second thing is, I think this is a journey we are going to start now with I think in the Shree's, I'm glad taking a lead, and also you have National Informatics Society. I think they can partner with a lot of actors who are helpful in Sri Lanka and move forward this. So I'm glad to be part of that journey also. And when you come to AI, we talk about the importance of data or the text or the input that you give. So if you think about like when you think data, it has to be flawed. If it is flawed, bias or poor quality, your output would be the same and your results would be the same. So it's called garbage in, garbage out. So I want to emphasize this actually severely. If the data you input is important when it comes to AI or any technology, because you create prediction or you create your output based on the data set that you input into the system. If you don't have a really very high quality data and correct and precise data, your output would be the same. So that means we are dealing with patients, right? It's not like, okay, somebody's like office assistant or something, it can be corrected later. But once you get into the patient care, you can't go back and change several things. This is the patient's life. So very important fact. So I'll come back to that when you think about what's happening in Sri Lanka and how do we incorporate that. And this is again, importance of good, I would say high quality electronic medical record system is really critical here. So if you do work on AI without having a good quality data set, and your like quality is suffered, and also the availability. If you don't have a good data set, you cannot use for artificial intelligence or any technology that you predict based on the data. And then interoperability issues, right? Because sometimes you have the data may not be talked to each other, but you need to predict certain things, but that's going to be affected if you don't have good data. And errors would be very high. So when it comes to patient care, we try to minimize the errors, so that's important. And privacy concerns is huge. I mean, this is particularly true in the US. You can't even access a data, a family member's data, unless you have the permission from family member. So privacy is huge when it comes to data, and then especially we have this hacking, cybersecurity should be important. So because of that, privacy concerns important when you think about EMR, EHR. And then the data quality while managed, we need to make sure we have a good governance and regulation of this data. So who's going to manage? And then if you don't have some sort of a universal or some sort of a national level good EMR, you try to do small scale AI without coordination, that's actually not going to go anywhere. In the US, that's happening. So there are several startup companies. It seems like it's the startup industry cost is higher than healthcare GDP. So if they use different technology for different reasons, and if without any coordination, you just have a one-off outcome, but that's not going to be helpful, not necessarily for sustainability and long-term patient care outcomes related. And so AI is not necessarily actually transforming, and it's from a theoretical concept, but it is from theory to practical. And from the diagnosis before patient comes to the doctor's office, at the doctor's office, and then follow up and administrative. I'm going to walk you through some example of AI function that's right now available and used. I'm not going to talk about the name of an industry or entity who's like making it, but I'll talk on the function that's being used. And in the US, when you come to healthcare, we have aims. What is the aim of healthcare systems in general? We have quadruple aim, we call it. And first is improving population health. Yes, improving individual patient care, but it's also important to think about at the population level. And second is reducing the cost. It's really important because US spend 20% of GDP for healthcare, but outcomes are not great compared to similarly developed nations. That's really important to think about cost, but decreasing cost doesn't mean we suffer quality. So we need to think about value. It's called value-based care. We improve the quality or keep the quality, but decrease the cost. There are several models in value-based care. I'm actually part of some of the state level initiatives. So trying to identify how to reduce the cost. And also another part is enhancing patient experience. We as doctors sometimes say, oh, we give treatment and patient needs to take care of that and take the medicine, everything will be fine. But we are in an era now, patient engagement is very critical. If the patient doesn't take some responsibility and also understand what they have to do, I think it doesn't matter what we do. So it's patient experience and engagement is key. And then during COVID, we realized how much healthcare workforce is burnout, stressed. So that came after that, and now provider or healthcare team satisfaction is also part of this quadruple aim. I'm going to talk about some AI tools that we use for different functions in the continuum of patient care. So we'll say you are in a clinic, patient is going to come and see you. This is before patient even come to see you. And there are a lot of robotic automation process out there. So for first, scheduling the patient appointment and reminding the patient, and then also gather patient age, gender, social status, economic status, or if whatever relevant to patient care. And then also some of the background verification, and especially in the US, you need to make sure insurance related information that can be automated. You don't have a person, individual, somebody is looking at this carefully and inputting this data. Now it can be automated. And another pre-visit automation is certain labs. If you had a follow-up, did you do your full blood count? If you do your CBC and stuff like that, you can automate. And when the patient comes to see you, and so we have that, and patient comes to the clinic, and then you have a chatbot, you just sign in, so you don't have to like worry about that. And then we use a lot of analytic. We have the electronic health record, right? And then electronic health record now will say, if I see a patient at Johns Hopkins or any other place, and then you need to make sure when patient comes to you, you have the right data, right amount, right time, rather than abundance of data that's not even useful. So now we have the technology within the electronic health records that you can get that data available to you when you need and right amount. So this is a very cool tool. I just want to mention, actually, this is piloting at Johns Hopkins right now. It's called Ambience Healthcare. I mean, there are several vendors doing this. So this is what it is like, documentation is very important in healthcare in the US. One, yes, it's all depend on what you documented in the history and exam on the medical record, because it's the electronic now. Everyone can see when they want it. Number two is there are several insurance agencies actually have patients are being actually enrolled in. So we need to make sure we send the right data to different insurers. So that's important. And then that also goes with billing codes. And number three is like the follow-up. And if you have a good documentation in the electronic health record, so you can follow up, what's actually being discussed by the other physician, and if somebody else is the patient next time. We have 100% electronic medical record at Johns Hopkins. And then other important thing is malpractice litigation. US is a system. If you miss a diagnosis, people can sue you. So unless you have a proper documentation, you cannot actually argue in the court on your behalf. So because of that, it's really important to have a good medical note for your doctor-patient interaction. So this Ambience Healthcare does is, so it is a piece of technology in the doctor's office. It does listen to your conversation, and it transcript everything and give a report to the doctor about the note and write a report to the patient. So you have that notes done immediately as you speak. So it's really important. One, it improves efficiency. Number two, it definitely improves satisfaction. And it has been shown physician burnout is high because of the pajama time, we call it. Doctors actually see the patients during the day when they go home, and they go into electronic medical record and write notes. Now, actually, that can be eliminated if you want. That right now, it's happening at the pilot stage. So this is a very interesting, cool tool that being used. And then when the note comes out, doctor can edit if they want and edit for the patient. It's a really less time consuming than what has been there before. And talking about now, that is at the doctor's office. And then the diagnostic standpoint. So there are tools now, analyze, take some pictures of your skin, and looking at all these pictures and looking into a system, it can diagnose melanoma and certain skin conditions. And this is between AI and doctor diagnosis is much higher. And other thing is like a causal relationship. So, right, like certain diseases are caused by just genetics. Some could be due to genetic and behavioral. So it can actually collect all this data and, work with the systems and come up with the causality, looking at, these contribute with attributional risk. Some of them are like higher risk. That's the reason you have this condition. And especially cardiovascular disease, which is the number one killer in all these conditions at a population level. I think AI model is superior to traditional model in CVD prediction simply because it can handle so much of data that you and humans are impossible to do. And we have at Johns Hopkins for somebody who's admitting a patient, sometimes DVT prophylaxis decision tool. So you just put into a system and then say, these are the risk factors. Yes, you can decide what DVT prophylaxis we use, similar to diabetic management algorithm in the hospital versus outpatient. There are several development happening. Sometimes you as a doctors can't keep up with that. So these tools are helpful. I mean, some may argue these tools are dumbing down doctors, but we are moving in this direction. So we may have to learn sometimes system while you also, improve your education or learning. And then there are a lot of tools for outpatient settings, screening and immunization recommendations. And during COVID, we have a tool inside the hospital putting into the different patient factors, and the diagnosis of COVID comes, and then also what test needs to be done, how the follow-up happens, and the management algorithm and discharge plan. And this is another area actually which advanced heavily, pathology. And because pathology is looking at slides, right, like it's rather than human contact. So breast cancer, if you look at breast cancer, sensitivity has increased to 90% compared to just pathologists looking at the slides. So these are studies at this point. I don't know how widely used this for just purposes of diagnosis, but I think the best is if you use this along with pathologists. I think that's where you get the benefit. Similar to colorectal cancers, is increasing these cancers now for younger population. It's important to have a good screening tool so that you can diagnose early. For colorectal cancers, 94 versus 88%. Melanoma, it's like 95%, surpassing 88% of dermatologists. So what this says is, like, at least at the research level, these have been very useful in terms of diagnosis. And when it comes to imaging. So I think this imaging actually sometimes used heavily now, diabetic retinopathy. So diabetic retinopathy, because diabetes is very common now at the population level. So retinopathy is a complication. We all know it can lead to blindness if you don't act quickly and treat quickly. So there are tools right now, and FDA actually approved one of them. And then you will have a camera at doctor's office. You just put your eyeballs into the camera and it takes some pictures and automatically read and say, oh, do we have diabetic retinopathy or not? So what it does is it decreases the cost, and it decreases the need for having ophthalmology on site. And it's also important for people who are hard to reach, like a vulnerable, underserved groups. And then the accuracy is 95%. So one good thing about these things, these accuracies are going to go up. Unlike like in the past, we do a study, it take a long time. This uptake is quite soon, and it's going to happen soon. And then if you say diagnosis of Alzheimer's by AI model earlier, 7 years in advance, that's really good, right? Like you can think about at least to do some lifestyle changes, although you may not have treatment right now. I mean, that's always a barrier. You say like you develop an AI tool for diagnosis, you also make sure you have something that you could do to prevent or treatment. If you don't have, it's a problem, but at least like we know if you have a disease. And I mentioned again, pancreatic cancer patient, they can be diagnosed much earlier with looking at some of the imaging, if you like have done in the past or if you do it now. And when it comes to treatment, so now I could talk about diagnosis. In terms of treatment, now there are models, you can get personalized treatment. So looking at your risk factor profiles and side effect profile, your genetic profile, and then system would give you your individualized treatment, especially happening in cancer world. And then also we use in a rudimentary way, robotic process automation system using patients are being prescribed correct medications, because electronic health record system is connected to pharmacy. So you can see if the patient is getting discharged or picked up the certain medications. You don't know until patient takes the medicine. It's a different system, but at least you can look at that and track that. And then IBM Watson is your oncological treatment and survival plan. Then after discharge, so you had the patient, you saw the patient after discharge. And then this area is hugely developing and revolutionizing everything, remote patient monitoring. And we have technology now, Apple Watch or any other watch also can detect your heart rate and your changes in different things. And then you can actually transfer that information to the doctor. That's remote patient monitoring. And then nowadays, patients are actively involved in tracking their health metrics, right? With the invent of wearable and mobile apps. And then also we have system that will say doctor prescribes certain treatment plan. There are systems in place that you can follow those treatment plan and just to check if the patients are taking those medicine. And we also have like early detection of health risk, especially we'll say patient is getting discharged after heart failure. So you need to make sure weight is monitored and patient's diet is captured and taking the medicine, when to give Lasix or not to give Lasix is important. So those things can be captured and sent to your own doctor by using remote patient monitoring. And another area really actually taken up quite a bit is patient education. I'm actually the co-chair of patient education committee at Johns Hopkins Hospital. So we have different new initiatives. Number one is virtual assistant. So virtual assistant help you to understand certain condition to you, your family or caregivers. And then the next is like you can personalize the education. We'll say if somebody has heart failure with systolic or diastolic or any other, you can just customize that to patients' literacy level and the need. And also we have a lot of interactive education tool, like using avatar, like before colonoscopy preparation, so patient understand. And then chatbots, and that's also helpful in terms of understanding the disease well, and then so that patient can be part of this discussion. And then the understanding is important in terms of tracking and engagement. And that's, as I mentioned, that's one pillar of this quadruple aim of in healthcare. And administrative simplification is huge. As I mentioned previously, US has a very complicated healthcare system and administrative tasks taking up a lot of workforce. It's costly, and then it's like high intense. So if there's a way to simplify that, I think that can save a lot of money. So that's also advanced. I mean, that's in some ways you can say it is a low risk because it's not necessarily directly affecting patients. It might be indirectly, but that's something really important that we invest on administrative simplification. So now we have a system to improve workflow. So in the hospitals, as I said, very complex. If there's a way to improve workflow, people know when to do certain things, that's important. And then recruitment. So I don't know, some may argue recruitment, shortlisting candidates, AI might be not a good thing because you need to look at individuals as individuals. And then scheduling, I mentioned. So you can schedule your appointment now just using the My Chart. We have every patient at Johns Hopkins has My Chart. So I look at my chart and I can set up my appointment on my own. So those are simplification. And then those information goes to the doctors. And I mentioned healthcare is run in the US by like billing and insurance information and claims. So if there's a way that we can simplify that and the reminder, patient follow-up reminders, that would also significantly save money and time. Another important concept in the US is called prior authorization. So I think it's a part of regulation by insurance companies. So we'll say if you have a disease and you need a certain medication, but certain medications are quite expensive there. And then if you want to really prescribe that medicine, you need to get a prior authorization from insurance companies. So it is really a very arduous process and it takes a lot of time. So now actually there are process automation for that, and that's helpful. So that's been heavily used as something real success in this journey. And coding assistance, because again, I mentioned it's important for billing and insurance related. And also because of this somewhat like we could see what's happening, doctor and payer alignment is important. Always there's a friction between what doctors need for patients and what the payers need. Payers want to cut the cost, doctors want to treat the patients. This misalignment is huge, but hopefully with advent of this new technology, we can see what's happening behind the scene. And as I mentioned, clinical disease support always available. And this is another area, hugely impactful drug discovery. Because drug discovery in the past, it took many, many years until you think of a drug or like an idea to get into the drug that can go to the market. But now that can be actually a very rapid process that can be designed quickly. You find the correct population very fast because you know who the people who can benefit from that. And then clinical trials can be done fast also. So then the cost of R&D, because all these companies take huge money for R&D from the government, and then we can actually, if they decrease the cost and decrease the time, so we can think about having the drug discovery faster is improve health. And these are some of the things that at the hospital operation level, that this is improving cost and efficiency by scheduling, recruitment, data management, increase efficiency in imaging time. But if you know certain test will say MRI is a waiting period, but if you know who needs the immediate MRI versus if there's a way for risk stratification, that's be helpful. And definitely improving labor costs. You don't need a lot of people to do certain tasks, that the repetitive manual kind of tasks can be done by the computers and by process automation, and increase accessibility. It used to be, patients need to see the doctor. Now maybe we can reach to the patient by hospital at home or telemedicine. Just moving into medical education, I'm not going to talk a lot about medical education, but there are a lot of new development happening right now. And then some of the example is using virtual and augmented reality for immersive training experience for doctors and physical therapists. We still, I think in the US, they try to use cadaver experience, but they also try to use virtual and augmented reality so that people can see the different muscle layers, neurons, much more than what we learn at the medical school. And then simulation trainers with haptic devices. When you have haptic devices, you get the same feeling, touch, vibration. So that would help people to understand. It's more like experiential learning. And we know this is a e-learning platform is out there everywhere. And gamification. So, when we were in medical school and the school, people would teach you, we learn it, we need to memorize and regurgitate. But now the system is different, right? Like you need to have that educational experience. Generations are very different. New generations, they don't like to listen to lectures. So we need to make them interesting. So one way is gamification, involvement in like more experiential learning. And AI is used for a lot of evaluation tools and feedback, and feedback also in terms of 360 feedback. So use a lot of AI tools. And there are challenges too, right? Like we'll say AI and students might use ChatGPT for like coming up with their essay or something. But we need to think through very carefully how AI is used in different level of educators, from medical students to others. I mean, there are ways, it needs a lot of thinking and a lot of like human understanding of how they are being used and how we can help them to use, rather than just to say, oh no, ChatGPT, because that's not going to go anywhere with new generations. And then we need to make sure we are aligning with this AI development and what are theoretical needs of understanding of different things in medical education. And public health. So another discipline, AI use actually much more. I'm just like writing like one or two because some of the important one, it's public health surveillance. And even during AI, during COVID, like people were able to predict disease in certain communities, certain areas much more than others, just looking at some of the data and patterns. So this going to get advanced and improved. And this is forecasting, same thing. And risk prediction, right? Like you can look at certain communities with certain risk factors and say, these are the ones going to happen to this community, just purely having this data. And then one thing important when it comes to public health is in the US especially, public health community and then the sick or like the hospital community doesn't collaborate that much. So this technology hopefully help to bridge that gap and help people to communicate more, so that hospital would send like certain information to public health professionals and they send us, it's a seamless connection would be possible. In summary, these are the things I kind of summarize some of the places where AI and the AI related tools are being used in the hospital, from diagnosis to patient care to treatment and medical education and drug discovery. But, having said that, there are so many challenges. I mean, yes, there's a promise there, there's a scope, and then we feel like that AI will add to a lot of patient care, but there are a lot of challenges also. And as I said, US healthcare is extremely complex. And one is it has many different systems. will say you use EMR for one thing and then process automation for something. Even at Johns Hopkins, it seems like more than thousands of systems within healthcare when you come to clinical care. So it is really hard when you think about, improving care by AI if you don't know what those systems are clearly and how they interact each other. This is a list of challenges, but it's not comprehensive whatsoever. Code bias, right? So this is really important when you will say I admit a patient, I see a patient, because we have to code each and every condition of the patient. Sometimes we choose, it's far from perfect. Sometimes we choose what is out there immediately. We'll say heart failure with preserved ejection fraction versus heart failure. I choose what is out there easily because nobody's looking at it. So that bias is translated into when it comes to the data. And generalizability. I told you having a good quality data is really important. We want to make sure that the data is generalizable. So we say there are data in the US. Most of the technology used in Western world has a separate set of population characteristic and geographic characteristic. If you're trying to use that in Sri Lanka or other country, there will be so much differences. You may not get the same kind of a quality output that you are looking into when you are that same tool is used in a different country. So generalizability is really difficult. And then also right now, this is everyone is having started company just because of the profit-driven design right now. But because of that, what they want is quickly get to the patients or out to the market, rather than really thinking through what the down the road consequences and what are the unintended consequences are. And then the development rate and adoption rate may need to be aligning, because sometimes people try to develop something and then try to quickly send it to the market and to the patient, but then we don't know patient's involvement and whether patient can use it or population can use. And then physician knowledge check, right? We'll say that I showed you very cool data like ambience healthcare. Somebody is checking what the interaction you had with the patient and it translates into a note. I mean, I don't know, this might affect stigma towards different physicians and licensing for them. And we need to make sure doctors are bombarded with abundance of data, because we need to make sure right amount of data available right time. And it's very critical to have oversight and governance. There's a black box inside the ChatGPT or the artificial intelligence tool. Some of them, we just need to make sure we understand what's happening inside so that we can have a meaningful outcomes and conversation. Ethical issues are extremely huge. So we don't know how it's going to affect doctor-patient relationship. Doctors, we think about empathetic, compassionate individual, but if the AI come into play, how it's going to happen. Transparency, I mentioned previously, certain like a rudimentary tasks, you may have transparency, but if you get to more complicated tools, we don't have that transparency. Especially important in a country like US, malpractice litigation is quite high. If you don't know what the AI is doing behind the scene, when you come to that, there's no way you can understand or explain why you make certain decision at that time. And then hallucination is a known factor for when you input a lot of data, output could be variable. We don't know. They change, and it's like sometimes act weirdly. And interoperability is important. And then we need to make sure doctors are on the table when it comes to development of these. This is a snapshot of some of the challenges. It might be more for different communities, different places. So then the question comes, okay, now we said there are challenges and there are some benefits of AI. I mean, I think benefits outweigh some of the challenges if you do it correctly. So, and especially there's a huge workforce deficit of healthcare workers, period. It's not doctors, nurses, and any other way. But at the same time, AI is trying to narrow that gap using some of the repetitive manual tasks can be done using AI. So hopefully that will be helpful. But at this point, doctors, at least in the US, call it augmented intelligence rather than artificial intelligence. Because now doctors, without doctors, you can't function a healthcare, you can't have a healthcare system, because it should augment our abilities rather than replacing doctors, or even thinking about replacing, because right now AI plus doctors would do better outcomes and jobs rather than anybody else. So I'm going to touch upon, so because American Medical Association, I'm not a spokesperson, but they put out this guiding principles in terms of AI, because it's going in extremely rapid rate and nobody has control over that. This is also, you might argue, this is also at principle level. It's not definitely a comprehensive, but at least they are trying to be on the table and helping AI companies also to think through this, and it become regulations rather than just people do on its own several things. I mean, their principles are AI must be designed, developed and deployed in a manner which is ethical, equitable, responsible, and transparent. I mean, that's a very good in principle. We just need to make sure what the details are. I mean, there's a document you can read if you're interested. And then the important thing, oversight of healthcare augmentation, augmented intelligence. They use the word augmented intelligence. It has to be whole government approach. The reason why I tell that is in the US, there are many states, like 51 states. Each state has their own governing body. So some of the healthcare regulations are done at the state level. But when it comes to AI, I don't think that's effective, or nobody thinks it's effective, mainly because AI is not confined to one geography. It's cut across countries, and then so it has to be done at the national level. That's the one distinction compared to, we'll say, malpractice suit is done at the actually level of the state. They have different regulations, although it can be at the national level, but AI oversight should be done at the national level. And then very important to have transparency. I mentioned why transparency is, because we are dealing with patients, not necessarily just other tasks. So we need to make sure what we do has some transparency, not necessarily maybe for the doctors. Somebody go in and should be able to check what the steps from data to outcome. And then when it comes to this chat GPT, and then again, we need to have policies, and because there are so many risks can be associated with like a generative AI like ChatGPT. So we need to make sure that the appropriate policies related to that, rather than the policies that has been used for narrow artificial intelligence. So it has to be incrementally similar to what is augmented intelligence does. Because US has a very strict patient privacy called HIPAA. So we need to make sure data is protected properly when you enter into any of the system. So that's critically important, because unless, I'll tell you an example. We'll say now you do in Amazon, you're looking for shoes. Next time you go in to any other website, shoes advertisement pop up, right? Because they can just system learn from your search pattern. But you don't want, in a world like, we'll say you have a heart failure or something, and the next time you into the computer, they give like heart failure related medication information to somebody who's looking at internet. It's going to be so confusing. One, I mean, it is just the patient privacy is violated. So we need to make sure these regulations are very strict, and then also has some consequences for people who are not following them. As I said, physician liability is very important in the US standpoint, because you only can access your data. You cannot access others' data unless you sign papers. So need to make sure this highly confidential, and safety is critically managed, and in this technology use, and data privacy, similar thing. And recently, a lot of cyber attacks for data breach happen at the healthcare level. So we need to make sure that cybersecurity and fair use of AI is managed properly. So have strong protections against manipulation and malicious attack. And then also payer, this is an important concept. Like sometimes payers, like insurance companies, use our treatment pattern to decide this doctor is better versus the other doctor. So that's actually something A may discourage or doesn't say, like payers should not use any kind of this tool to rank doctors. So I would, these are my last couple of slides. So I want to just to leave you with, because AI is rapidly developing. However, I think it's mostly happening in the West. So, but as we look into some of the new development, but each journey should be unique. Why I say that? Because as I mentioned, data sets are different. One, our challenges in Sri Lanka is very unique, and cultures different, resources are different, economies and societies are different. So all these systems are driven by having the data that's relevant to that population. So you cannot use the same system that you use in other countries in a different level. So AI systems should be unique. So I'm glad that Sri Lanka is taking some initiative at national level with proper stakeholders, and then hopefully that can produce like a roadmap for the country. So I was just in Indonesia last week, and there was a conference I attended, and there was that was along with Ministry of Health in the country. So they do have a digital roadmap, and so what is important is when you think about a digital roadmap, and you need to first do the needs assessment, similar to any other project. So there you identify the gap, and then you find out what works well in the country and what doesn't work well or what the challenges are. And then working with variety of groups, including patients. That is the key. Patients or the population, general population needs to get involved. And then, as I mentioned, national coordination and governance is the key here. What they identified is similar to any other country. There are so many systems out there in healthcare, but they don't talk to each other. It's like a fragmentation in multiple systems, causing lack of interoperability. You have data, but you can't use the data. So you need to make sure how to harmonize that data. And then in the US, the body who's making this kind of guideline scale, National Office of National Coordination. So that group actually produced their guiding principles, and they have this overarching goals to promote health and wellness, enhance the delivery, and enhance the experience care of accelerate research and innovation. And then also connect the health system data with health data. This is very important because you say Johns Hopkins has their own data and the University of Maryland is the other institution. They have their own data. How do we like cross connect? Because patient doesn't care, goes to Hopkins or the other place. So we just need to make sure we have the interoperability. And India has actually another national digital health mission. India has several startups and it's actually leading some of them. So these are their guiding principles. They want to make sure it's interoperable, it's available right time for the patients when they need for doctors. In conclusion, so AI is transforming, AI and every technology is transforming practice of medicine at every level, and a rapid pace that you can't even understand. And it's in one way is opening a new era with several challenges. And I mentioned before, AI system shown to augment clinicians and educators' role and assist in quadruple or any number of aims that you have in healthcare. So they should help us. And then AI should be designed, developed, and deployed in manner ethically, equitable, responsible, and transparent manner. And then it's really important to think through code to bedside. So you have this code you put into the system. How is it translated into bedside? You can create thousands of new systems, but it doesn't translate into patient care. You're kind of wasting time and money. And then lastly, I would say governance and regulation might be better at a national level. I think that's my last slide. Thank you very much for listening to this talk. As I mentioned, I'm extremely honored and privileged to be here and physically in Sri Lanka at Sri. So, and also glad to be part of this journey that's going to start. And thank you very much.
Thank you very much, madam. And there are some questions in the chat box. This one, as the current data sets originate mainly in the global north, these models created can be biased to such settings. What actions can be taken to safeguard the countries like Sri Lanka in the global south being affected by these biases?
Speak up and tell me a question, or I don't know how many questions you might have.
Uh, just asking like, are there enough legal safeguards on the current context of medical practitioners of these AI tools? And who is responsible for the model creators uh, or the doctors?
Are there enough legal safeguards in the current context of medical practitioners of these AI tools? Who is responsible for the model creators or doctors? So yeah, you are right. So right now, I'm just speaking from the US context. So a lot of AI tools are developed not using real patient data, mostly hypothetical patient data. So it's another question is whether even it's valid. But then also other side of it, Apple Watch, they collect a lot of data, right? We might just opt in or opt out what the method is. Maybe they are using our data. They claim, say they are improving their systems. But whether that's accurate or that's the ethically sound, I'm not sure. But what I say is you are right. So legal safeguard needs to be done. At least now the conversation is happening. So, and then you say, like, when you come to patient care, right? Some doctors might use AI tools, some may not use, but in future, we may all have to use these. And then enough safeguards in the current, okay. So right now in the US, we don't use that much of like data or AI tools that's lack transparency, but it is going to come. So that's the reason even American Medical Association or ONC has this guiding principle so that we understand before it fully come to practice of medicine. And then you're absolutely right. Who's responsible? Is it AI company responsible part of it or doctor responsible part of it? We don't know. That's yet to come. So I'm going to, I know you have some online tools. I'm going to give Sri some recommendations so that they can share with you all. Okay, so that's a good question. Next one, what is your idea whether AI will eventually replace human touch in medicine, including empathy and health research? Yeah, so as an individual, now I'm speaking, right? So yes, I think it is a kind of a concerning thing. You think it's a challenge too, but I feel like right now, I don't think it's going to happen. You still, when a patient is sick, they need doctors, empathy, compassion, altruism, or anything that you use it, right? You need that human touch. When we become sick, that's what we need too. It is still there. I think AI would help us. That's the reason we use like, or even AMA, and everyone uses augmented intelligence. So I don't think it's going to go away. But we'll say 20 years down the road, we'll say there may be, this is again speaking as an individual, we'll say we have a call, we might go to a chatbot in a store in the US, we'll say CVS or somewhere, we say, I have these conditions, and then they'll prescribe medicine. I think there will be a time like that, but then I don't think doctors completely will be replaced, but part of doctors will be replaced. I think people who are proponent of AI saying, no, this is never going to happen. It's going to help doctors. Yes, right now that's true. In next 10 years, it's true. But I don't know in 20, 30 years. But the doctors' roles will be very different. So the same argument, I would say, medical students, right? It used to be, okay, we knew what the medical profession we were going into. It says either calling, like, okay, you have to serve the country, serve the people. So that's like a calling for become a doctor or service oriented. Or sometimes it's like a profit driven, or like this other reason I become a doctor. So that's actually then some may argue, okay, now the doctor's role is going to be different. Oh, do we really need to go into medicine because it's unknown territory? But some argue saying, oh, this is an interesting time to become a doctor because so many new things doctors can be part of. But the other side is like previously mentioned, Are you really going to be a doctor, or you are really going to play a different role with machines? So, but right now I would say yes, the empathy will be there and it's important to have it. Next one, I'm reading so many questions there. What is the state of accountability and liability of AI made decisions? I think it's, as I said, right now, we, at least right now on the market or in hospital setting, the tools that we use is properly vetted and tested. So in future, we have to make sure these, the new tools coming up with generative AI, especially, so we know what's happening behind the scene. Yes, responsibility and liability and reliability is very important, because if the system can hallucinate and give a different results than whatever that you input it into, so that's going to be a challenging too. So that's yet to be actually seen. Okay. I know ethical considerations are huge, and patient privacy, as I mentioned, some of them are really needs to be very clear. Even though you are really, you put a lot of layers of protection, still bad actors can get into your data and use in a way that's ethically or unethical manner. So we need to make sure these safeguards are in place, especially I think a resource limited setting. We need to make sure that people are not using this data to create their own like profit-driven design in another place. So please share experience in attitude of doctors, healthcare workers. Okay. Oh, that's a good question. So I'm the president of Maryland Medical Society. We are doing a survey just to see what doctors want, but the American Medical Association did a survey. So overwhelmingly, they don't like AI. That's their attitude, right? Like they say, okay, this is going to replace, they are not ready. So, but what the argument is, it doesn't matter, you are not ready, it's going to come. So how do we support doctors in an incremental manner? So not necessarily putting out every day. When the EMR is done, that's what happens, right? So you put out everything, nobody wants to adapt or use it. So we want to make sure it's introduced in a manner doctors are part of that discussion. So this is true, it's going to come, but overwhelmingly doctors don't like this tool. In some ways, there are many reasons. One, they don't want to learn. Number two, they don't rely on some of them. Number three is they don't have any confidence on this system. Or number four is like whether they are going to replace us. So many reasons why they have this skepticism on this. I mean, it's okay to be skeptic about that, but we need to make sure we look at the positive side of it, right? Like we became doctors to help patients, we'll say. So we need to make sure if it is helping, why don't we use it? So we just need them to be part of the discussion. And then when you introduce this kind of thing, we need to, we'll say, so in Indonesian conference, I got someone from Sinai to speak about challenges of electronic health record implementation. I mean, he showed how hard it was to introduce electronic health record to the physicians and the team members at the Sinai. So it was a huge learning for that. Sometimes I think Sri Lanka or any other country who's trying to deploy can learn some of the best practices. Of course, there has to be cultural sensitivity and differences has to be mitigated or somehow used to interpret this information, but can we use some of the challenges? I think Rest said thank you. Okay. Can AI-assisted digital application be allowed to prescribe medications without supervision of doctor, or only allow diagnosis and prevent false narrative due to human errors? Yeah, so right now, we are not using, at least at Johns Hopkins, we don't use prescription by on its own without human interaction or influence. Yes, there will be a day for simple conditions that you go and look at a chatbot or anything like, and then say, okay, take augmenting for this or antibiotic for certain condition. That will come, but you are right. Like there are a lot of human errors, right? Like in terms of certain conditions, it's a complicated decision making. There are some human error can happen, but those can be minimized. And then right now, we use so for diagnosis standpoint, but still a lot of human influence is there at this point. In future, it might decrease, but to the level, I think I'm glad that all the doctors' bodies are part of that, the making these decisions. And then a bigger argument is what is the future doctor is going to be, whether they really need to learn everything, right? They don't. It used to be in medical school, we had to learn about every medicine, side effects, doses. I mean, we don't need to learn anything anymore. It's all out there. So, but then can we use that energy or that cognitive reserve for something else is a good question. So those are highly debatable. This is like, as I said, I'm giving the snapshot of what is out there and what is possible. Some of them are as an individual I'm speaking, but definitely certain things need to be carefully thought out. Any more questions? But I know I'll share with you some of the resources. Somebody asked a question. So if you do have a question, you can email me. I think they have my email address, right? Okay. Putting comments or anything that we should be doing before adjourn the meeting?
Okay. I think that's it for the day, madam. Thank you very much for participating today with us for this session. And our sincere gratitude for Prof. Padmini Ranasinghe, Department of Medicine, John Hopkins School of Medicine, USA, and her excellent lecture and her precious time on today's event organized by the Sri. Thank you very much, madam. And there's a link in the chat box. And for the participants to fill and kindly give your feedback, and you can answer the post assessment questions, and then you will receive your e-certificate for the participation. Thank you.
Thank you very much, everyone. I'm glad to be here. I'm a Sri Lankan, so like to pay back to Sri Lanka in any way I can. So thank you again.